طبعا انا اكيد سعيد ومبسوط النهارده في اول برزنتيشن ليا في مؤتمر لاسم النفرولوجي، وانا مدرس. ان شاء الله نحاول نختصر في وقت البرزنتيشن. احنا النهارده هنتكلم عن الممبرينس نفروباثي ليتست ريسيرش، استكمالا طبعا للكلام اللي بدأته دكتوره منال. Membranous nephropathy is one of the most common causes of nephrotic syndrome in adult. Term membranous nephropathy reflects the pattern of histologic change noted on light microscopy, glomerular basement membrane thickening with little or no cellular proliferation and filtration. That membranous nephropathy is a descriptor for a particular region as detected by histopathology and doesn't by itself refer to a single disease or common pathophysiology. The disease characterized by deposition of immune complex in subepithelial space, which eventually leads to thickening of the glomerular basement membrane. Classification يمكن الدكتورة منال قالتها برضو، البرايمري السكندري الالوميون، وطبعا في antigens implicated in membranous nephropathy ودي اللي هنحتاج نركز عليها شوية. الفوسفولايبيز E2 receptor antigen and antibody, the transmembrane glycoprotein expressed by the human podocyte responsible for primary membranous in as many as 80% of patients, reflecting approximately 55% of all membranous nephropathy cases found on biopsy. Thrombospondin type 1 domain containing 7A, multi-domain protein expressed on the basal surface of the podocyte immediately beneath the slit diaphragm. Account for 1 to 3% of membranous nephropathy cases. Other antigens like neural epidermal growth factor, semaphorin, exhaustin 1 and exhaustin 2, mainly in cases with lupus class 4 associated with membranous. Identification of target antigens has allowed for more precise molecular diagnosis, and the ability to monitor circulating autoantibodies has added a new vantage point in terms of disease monitoring and decision about immune suppression. We can classify, depending on phospholipase E2 receptor antigen and antibody, membranous nephropathy to phospholipase E2 receptor associated with either positive immunofluorescence staining for phospholipase E2 receptor antigen on kidney biopsy or with detectable serum antiphospholipase E2 receptor antibodies. The most sensitive technique to diagnose phospholipase E2 receptor associated membranous nephropathy is immunostaining of the kidney biopsy for pilar antigen. In the majority of patients with phospholipase E2 receptor associated circulating autoantibodies directed against phospholipase E2 receptor can be detected in the serum. Non-phospholipase E2 receptor associated membranous nephropathy with neither immunofluorescence staining for antigen in the kidney or antibody in the serum. Patient with non-phospholipase E2 receptor associated membranous nephropathy may be positive for other target antigens associated with membranous, such as thrombospondin type 1 or neural epidermal growth factor, semaphorin, and protocadherin. Antiphospholipase E2 receptor antibody positive in patient with phospholipase E2 receptor associated membranous nephropathy, circulating autoantibodies directed against phospholipase E2 receptor are detectable. Antibody against phospholipase E2 receptor may be negative in membranous nephropathy. Circulating antibodies are not detectable. In these patients, the kidney act as a sink by binding all available antiphospholipase E2 receptor autoantibodies. If disease activity persists, antiphospholipase E2 receptor antibodies may become detectable with longer follow-up. Alternatively, some patients with undetectable autoantibodies may have already developed immunologic remission. In such patient, gradual decrease in proteinuria will become apparent. يعني في المقصود بيه ان احنا احيانا ممكن نعمل انتي فوسفوليبيز E2 ريسبتور انتي بودي ويطلع نيجاتيف، بس احنا بيكون البيشنت لسه مش دايجنوزد بالنسبه لنا، وفي الستيج دي بيكون الانتي بوديز اللي موجود كله بريسبتيتد في الكدني تيشو ولسه ما بقاش ظاهر معانا في السيرم. الكدني يعني تقريبا استهلكت كل الانتي بوديز اللي موجوده، فاحنا بنكون في المرحله دي لسه ما لقيناش الانتي بودي. فلو عدناه بعد كده ممكن لو المريض لسه في ديزيز اكتيفيتي نلاقي ان التتر بتاعه هيعلى. Confirming the diagnosis of membranous nephropathy in patient with a compatible clinical presentation is pivotal in guiding management and treatment decision. Kidney biopsy usually is considered the gold standard for the diagnosis of glomerular disease. However, for membranous nephropathy, antibodies against BLR2 biomarkers that can establish the diagnosis with high accuracy without the associated risk of biopsy. In patients who are phospholipase receptor negative, a kidney biopsy should be performed with a staining of biopsy for antigen, and this may disclose phospholipase receptor associated membranous nephropathy. This can occur in patients where serum ELISA immunofluorescence test is falsely negative. Moreover, it has been suggested that antibodies may be absent in the early phase, as we said in the previous slide. Updated algorithm to help in taking decision to take biopsy or not. If phospholipase receptor antibody test is negative, so we go to renal biopsy. If it is positive, according to the clinical condition with normal kidney function, we can hold without taking renal biopsy. But if we will need to give immune suppressive therapy or rapid deterioration of the kidney functions, we can proceed to renal biopsy. Patient with membranous nephropathy should be evaluated for associated conditions regardless with phospholipase receptor or thrombospondin are present or not, to exclude associated conditions that may be critical, like history taking, anti-nuclear antibodies, viral markers, ultrasonography, searching for malignancy. Patient may be presented with membranous nephropathy before we diagnose malignancy. For history taking also. So we can stratify risk factors for disease progression in membranous nephropathy into histological findings like glomerular scarring, biomarkers, phospholipase receptor antibody, urine low molecular weight proteins, beta 2 and alpha 1 microglobulins, thrombospondin antibody, and the clinical features like old age above 60, male sex, nephrotic range proteinuria, increased serum creatinine on presentation. All of these indicate poor prognosis. Treatment for patients with primary membranous nephropathy. General supportive measures in all patients with membranous nephropathy, including dietary and sodium and protein restriction, blood pressure control, minimization of proteinuria with renin-angiotensin system inhibition, treatment of dyslipidemia, and in selected patients, and coagulation, we'll discuss later. Other aspects therapy include diuretics and control edema and maintenance of adequate nutrition. In most patients, it is reasonable to wait 6 months for spontaneous remission while using maximal antiproteinuric therapy. High levels of proteinuria and phospholipase receptors low molecular weight proteinuria should lead to reevaluation earlier than 6 months. دي classification من كديجو 2020 للcases of membranous nephropathy into low risk, moderate, high, and very high risk to help in taking decision to start treatment or to wait and see. Like low risk cases, we can wait and see. Moderate risk, we can wait and see. But if there is deviation, we can start with rituximab or CNIs. And high risk, we start treatment with rituximab or cyclophosphamide or combine CNI with rituximab. In very high risk, it's recommended to start with cyclophosphamide. Commonly used treatment regimens in patients with membranous nephropathy, cyclophosphamide, taken alternatively with methylprednisolone, 1 gram for 3 consecutive days, months 1, 3, and 5, prednisolone 0.5 milligram per kg per day, months 1, 3, and 5, and cyclophosphamide 2.5 milligram per kg per day, months 2, 4, and 6. Rituximab can be given 1 gram twice within 2 weeks, or 375 milligram per meter square body surface area, given 1 to 4 times at weekly intervals. Tacrolimus can be given up to 0.1 milligram per kg per day with target trough level 3 to 8 microgram per milli, duration for 12 months. Cyclosporin also 3.5 milligram per kg per day, targeting trough level between 125 to 225 microgram per milli. Goals of therapy in patients with primary membranous nephropathy who are receiving immunosuppressive. The goal of therapy are to induce clinical remission, and in those who have positive serum antiphospholipase receptor antibodies to achieve immunological remission. Clinical response can be classified into complete clinical remission or partial clinical remission or no clinical remission. According to the response and the proteinuria level. Immunologic response, depletion of antiphospholipase receptor antibodies as evidenced by antiphospholipase receptor antibody titers below the cutoff value for positive result. and or negative indirect immunofluorescence test. الكيرف ده بيوضح الفرق في الريسبونس ما بين الانتي فوسفوليبيز اي ريسبتور انتي بودي تتر والبروتينوريا. فاحنا ممكن البيشنت يكون دخل معانا في ايميونولوجيكال ريسبونس فعلا وبدا يتحسن، والتتر بتاع الانتي فوسفوليبيز اي ريسبتور انتي بودي في السيرم بدا يقل، ولكن البيشنت لسه ستيل عنده بروتينوريا. فده هيكون مهم عشان انا ما اقدرش ازود مده الاميون سبريشن واخد سايد افكتس منها البيشنت وهو اوريدي داخل معايا في ريميشن. ولذلك ان احنا نعمل سيريال مونيتورنج الانتي فوسفوليبيز اي ريسبتور انتي بوديز ده مهم. ده برضو بيوضح معانا ان احنا لما نبدا التريتمنت سواء بالريتوكسيماب كالسينيورين انهبيتور اور سايكلوفوسفاميد after 3 months we'll assess phospholipid receptor antibody if absent according to what we started. If we started rituximab, no additional therapy, cyclophosphamide will withdraw, calcineurin inhibitors will continue as in previous slide. If phospholipid receptor antibody showing no change in titer, so we'll give extra dose of rituximab or continue cyclophosphamide and calcineurin inhibitors. If it increased, if we're starting with rituximab, we give extra doses or add cyclophosphamide. If we start with cyclophosphamide, we can add rituximab. With calcineurin inhibitors, we can add cyclophosphamide or rituximab, and then repeat after 6 months and continue according to the result. In cases with relapse after initial treatment, if we started with rituximab, we can repeat rituximab again. If we start with calcineurin inhibitor, we can shift to rituximab plus or minus calcineurin inhibitors. If we started with cyclophosphamide, we can shift to rituximab plus or minus calcineurin inhibitor or repeat cyclophosphamide. Management of patients with treatment-resistant membranous nephropathy, which means persistence of proteinuria in parallel with persistent or increasing antibody level. We will assess the patient regarding estimated GFR level and proteinuria. If patient start with rituximab and have a stable GFR, we can add calcineurin inhibitors plus rituximab. If no response for 3 months, we can shift cyclophosphamide. But with low GFR, we can start with cyclophosphamide. With CNI, the same, GFR stable, we can add rituximab. Then, if no response, cyclophosphamide. If decreasing, we can add cyclophosphamide. If we started initially with cyclophosphamide with stable GFR, we can add rituximab. If no response, we can repeat cyclophosphamide. If GFR is low, we can repeat cyclophosphamide again. If resistant to rituximab and cyclophosphamide, consult expert. Okay. Anticoagulation therapy in patient with membranous nephropathy. Serum albumin level is below 20 gram per liter. Yes, if below 20 gram per liter, so there is high risk for venous thromboembolic events. We will assess the bleeding risk. If high risk for bleeding, we'll give aspirin. Low risk, we'll give warfarin or low molecular weight heparin plus aspirin. If patient has serum albumin above 20 gram per liter, is it below 30 gram per liter? Yes, estimate arterial thromboembolic event risk, low risk, no aspirin. If high risk, we'll give aspirin. If serum albumin is above 30 gram per liter, no need for anticoagulation. In transplant patients, we need a pre-transplant evaluation. Especially if membranous nephropathy associated with phospholipid A2 receptor antibodies. If patient with known to have phospholipid A2 receptor associated membranous nephropathy, we measure the titer of antibody. If it is positive, so he has high risk for recurrence, about 50%. If it's negative, antibodies have disappeared, low risk of recurrence, about 10%. If patient has membranous nephropathy but with negative antibodies, we can retrieve renal biopsy and stain for antigen. If positive, it means that antibodies may have disappeared, so it have low risk for recurrence, about 10%. But if negative, it has medium risk for recurrence. Discuss recurrence rate with the patient. Pre and post transplant monitoring period. We measure proteinuria every month. Proteinuria 1 gram per day, take renal biopsy. A patient with no phospholipase receptor associated membranous nephropathy will measure the titer every 1 to 3 months depending on the pre-transplant antibody status. If it is increasing, increase the risk of recurrence, so consider early kidney biopsy. If decreasing, low risk of recurrence, so perform kidney biopsy only if clinically indicated. Treatment of recurrence in post-transplant patient with angiotensin converting enzyme inhibitors. Optimize immunosuppressive therapy, therapeutic drug monitoring of mycophenolate mofetil aiming to be 50 milligram. Proteinuria less than 1 gram per day. So we'll monitor every 1 to 3 months. If proteinuria more than 1 gram per day, we'll give rituximab 1 gram at day 1 and day 15. Patients who are pregnant, rare case reports of primary membranous nephropathy in pregnant women have been described. The optimal approach to the treatment of membranous nephropathy is not known. As in non-pregnant patients with primary membranous nephropathy, initial assessment is required to determine the patient risk of disease progression. In pregnant patients with nephrotic syndrome, cyclosporin tacrolimus can be used. In those with normal or near normal kidney function, in general, rituximab and cyclophosphamide should be avoided in pregnant patients. Treatment of secondary membranous nephropathy in general, the treatment of secondary membranous focus on cessation of the offending drug and effective treatment of the underlying disease, which is usually associated with improvement in the nephrotic syndrome. Some patients with secondary cause of membranous nephropathy may test positive for antiphospholipase receptor antibodies. In such a patient, the possibility of two separate disease entities, primary phospholipase associated membranous nephropathy and coincidental secondary disease like hepatitis B virus infection malignancy must be considered. If the patient develops signs of progressively worsening membranous nephropathy, may need immunosuppressive therapy, especially if the underlying secondary disease has already been successfully treated. As regards the prognosis, patients with primary membranous nephropathy who undergoes continuous or drug-induced remission generally have a good long-term prognosis. 30 to 40% of patients who receive cytotoxic therapy plus glucocorticoids undergo complete remission of proteinuria. 30 to 5% undergo partial remission, and the incidence of progressive kidney function impairment is only approximately 10%. We'll give short hint about new medications in treatment of membranous nephropathy. ريتوكسيماب طبعا كان في توقع انه يتحط في الجايد لاينز بتاعت الكديجو 2020 سبيشالي بعد المنتور ترايلز، وبالفعل هو اتحط وبقى كورنرستون في العلاج بتاع الممبرينس نيفروبسي، وستيل في اونجونج ترايلز موجوده وبتتعمل عليه، سواء ان احنا نهلب او ان احنا نساعد في الافكت بتاعه باضافه ادويه ثانيه زي التاكروليماس او السي ان اي، او ان احنا نشوف حاجات الترناتيف تكمبيت معاه زي الاميون ادزوربشن. دي كانت الدياجرام بتاع المنتور ترايل باختصار كده. هو اثبت ان هو not inferior to CNIs في ان هو يعمل ريميشن، ولكن في النت ريزلت بعد 24 months كان الريزلت 60% ان ريتوكسيماب، ولكن في السايكلوسبورين كان 20% ان هو يمنتين الريميشن. في ongoing trials زي ما قلنا مع الريتوكسيماب، سواء كان بالبيبتايد جي ام اميون ادزوربشن ثيرابي، وده البريزم ترايل دي هي موجوده في الهيماتولوجيكال مالجنسيز وموجوده برضو في البرايمري ممبرينس هاند ان هاند. هم بيجربوا انهم يعملوا اميون ادزوربشن للبيشنت من غير ما يكون خد اميون سبريشن، وبعد كده هيقارنوا مع كل الاميون سبريسيف دراجز سواء كان ريتوكسيماب او الادويه الثانيه. وفي sequential treatment with tacrolimus rituximab versus steroid plus cyclophosphamide in patient with immune membranous nephropathy starman trial. وفي ال RI cyclo trial دي معموله في ايطاليا بتقارن الافكتس بتاعت الريتوكسيماب مع البونتنشال ريجيمن. في نيو دراجز بقى في البروميسنج بس still under trial زي الاوفاتوموماب. Ofatumumab is a new monoclonal antibody acting on CD20, differ from rituximab because it has different target epitopes. Ofatumumab, in addition to acting on the same epitope as it recognized by rituximab, also act on a second epitope localized on the small loop of CD20 and on a portion of the large extracellular loop. Ofatumumab has been assessed as a rituximab rescue therapy. Recently described two cases showed clinical remission with immune membranous nephropathy resistant to rituximab. so we can use it with cases resistant to rituximab. Belimumab, as a monoclonal antibody, belimumab targets the soluble form of B lymphocyte stimulator that has a critical role in the differentiation and homeostasis of B lymphocytes. The effect of belimumab on proteinuria and anti-phospholipase receptor antibody production have been evaluated in 14 patients with anti-phospholipase 2 receptor positive membranous nephropathy. The treatment significantly reduced the antibody titer with proteinuria within 12 weeks. Another treatment is targeting memory plasma cells. Advanced stages of membranous nephropathy could be mediated primarily by autoreactive plasma cells, which are resistant to anti-CD20 monoclonal antibodies, but sensitive to anti-CD38 antibodies or proteasome inhibitors. Memory cells survive rituximab because they don't express the CD20 antigen. Plasma cells express CD38. These autoreactive plasma cells could be target for anti-CD38 monoclonal antibodies such as daratumumab or isatuximab. Bortezomib is a proteasome inhibitor which may effectively deplete plasma cells. Bortezomib acts by causing an intracellular accumulation of abnormal proteins with consequent plasma cell apoptosis. Today, bortezomib has been used in anti-neutrophil cytoplasmic antibody nephritis and in resistant systemic lupus cases. Preliminary data suggests it may be useful in the treatment of immune idiopathic membranous nephropathy that is resistant to other therapies. The main drawback of bortezomib is toxicity, which necessitates treatment interruption in most of patients. Obinutuzumab is a fully humanized type 2 anti-CD20 monoclonal antibody, whereas rituximab is a chimeric type 1 anti-CD20 monoclonal protein. Type 2 anti-CD20 monoclonal antibodies are more potent beta cell depleters compared with type 1 antibodies. Few cases with phospholipase 2 receptor associated membranous nephropathy for whom rituximab failed to induce immunologic or clinical remission were successfully treated with obinutuzumab. بقيه السلايد هو بيدي بس بيشرح ليه الفرق بين في فرق في الميكانيزم اوف اكشن ما بين التايب 2 تايب 1 and CD20 monoclonal antibodies في البايندينج مع الريسبتور وفي التعامل مع البي سيلز. Targeting complement inhibition by the anti-C5 monoclonal antibody eculizumab could be another avenue for treating idiopathic membranous nephropathy. In this approach, complement inhibition could prevent glomerular damage that occur prior to the removal of antibodies. To date, attempts to treat membranous nephropathy by eculizumab have failed and studies remain unpublished. Mycophenolate mofetil, several observational studies have suggested that mycophenolate mofetil is effective for treatment of membranous nephropathy. Okay, thank you.